So we're going to discuss cirrhosis here and then some of the liver emergencies. And primarily by liver emergencies, I mean acute GI bleeding secondary to cirrhosis, which is one of the big complications of cirrhosis and a major cause of death in patients who have liver failure. So although I did talk about acute variceal bleeding in the hematemesis section, I want to go over it again with more of an emphasis on the hepatic problems behind it and some of the ways that you can treat it that involve liver surgery. Now there are a lot of liver emergencies that you could have, including hepatic encephalopathy, patients who come in with, let's say, in a comatose-like state or in a state of delirium due to hepatic encephalopathy. However, that's not a surgical emergency, that's a medical emergency, so we're not really going to be talking about that much here. We'll first just glance over the anatomy of the liver. We'll talk about cirrhosis and its complications. I do recommend, if you haven't already looked at the portal hypertension lecture that I also put up, do that, because that's going to be important for sort of understanding what these complications are and how they come about. We'll talk about something called the Child's Classification Score, which you don't need to memorize for the USMLE, but it's really good to know for clinical practice, and it's good for some of the general principles that you may need to apply on the USMLE. I wouldn't memorize it, though. Then we'll talk about varices, which is really the major complication, the major emergency that comes out of cirrhosis that's dealt with surgically on a regular basis. We'll talk about how esophageal varices present, why they happen, and then some of the initial therapies that we use, which are primarily endoscopic. And then we'll talk about the TIPS procedure, which is a radiologic procedure that's done sort of semi-surgical, and then emergent portocaval shunting, which is an open surgical procedure. Then we'll finally go into these procedures more in depth. And transplantation, I just want to point out, is sort of your ultimate treatment for liver failure, but we're not going to talk about transplantation itself. I'm going to spend an entire section on transplantation of organs later on. Okay, so here's the anatomy of the liver. As if you've seen these liver lectures before, you probably already know that the liver is divided up into two lobes. You have your left lobe and your right lobe, and the supply into the liver both comes from your hepatic artery, which comes off of your celiac trunk. The hepatic artery divide up into left and right. Then you have also blood coming in to provide some oxygenation coming in from your portal vein, and that's really the structure of disease here. This is the structure that causes a lot of the problems when we are thinking about sequelae of cirrhosis. Portal vein divides up into left and right as well. Draining the liver, we have the left and right hepatic veins, which come together and then empty into the inferior vena cava. And that's going to be important when we talk about the TIPS procedure. So cirrhosis is a histologic diagnosis. We think of cirrhosis with a lot of processes, but really in order to make an official diagnosis of cirrhosis, you have to technically get a biopsy. Does that mean we get a biopsy all the time? No. But we usually know cirrhosis based on what's going on with the patient, usually as far as portal hypertension. If they're developing those kinds of sequelae, we know that they have cirrhosis of some kind. What cirrhosis is a collagenization of the liver. The liver parenchyma becomes tough. It becomes resistant to portal flow, and that's going to increase the pressure, the back pressure in the portal system. There are many causes of cirrhosis. However, in the United States, intrahepatic causes are the most common. And of all the intrahepatic causes, which I talked about, some of the intrahepatic causes in the portal hypertension lecture, alcoholism is the number one etiology. So alcoholic cirrhosis is the number one etiology of cirrhosis in the United States. Other causes include chronic hepatitis B and C, autoimmune hepatitis, primary sclerosing cholangitis, primary biliary cirrhosis, hemochromatosis, Wilson's disease, cystic fibrosis. There are lots. There's also cryptogenic cirrhosis, which is sort of idiopathic sclerosis, where we don't really know why it happened in an otherwise healthy person. I've seen a patient who went from basically perfectly well to dead from cirrhosis-related complications in 2 years from cryptogenic cirrhosis. So this can actually strike you down pretty fast. The major consequences of cirrhosis relate both to the fact that you have backup in the portal system, which is portal hypertension, and from the fact that when you have cirrhosis, most of the time your hepatocytes are not functioning, and your hepatocytes are responsible for detoxification and getting rid of waste products. So there are two really big problems with cirrhosis. So first, from the portal hypertension side of things, this is going to be vascular issues. So when you have a problem with elevated pressure in your veins, you're going to get dilation of those veins. So dilation of the veins that bypass the liver, go around the esophagus. Those are your esophageal varices, which are notoriously problematic for patients with cirrhosis. You also have very deep down in your lower GI, there's hemorrhoidal veins, which ultimately most of them empty into the inferior mesenteric vein, rather, and then you have veins in your spleen. So what results from that are varices, hemorrhoids, and splenomegaly, which is just dilated veins. Then another problem from elevated portal pressure is exudation, and that's because of an elevated hydrostatic pressure. It's going to push fluid out into the available free space, which is the peritoneum, and so you get elevated peritoneal fluid, and that's ascites. It's basically the same as when you have right heart failure, you get pulmonary edema because you get increased pulmonary pressure. When you have cirrhosis, you get ascites because you have elevated portal pressure. Then the decreased hepatic function, primarily what that's leading to is hepatic encephalopathy. Of course, we also have to take into account that there's decreased clearance of certain medications, and that's going to affect your pharmacologic management of pretty much anything if it's a drug that's metabolized in the liver. But hepatic encephalopathy is the big complication that we see with cirrhosis as far as decreased hepatic function. So the management of complications, I just sort of listed some of the common ones here. We're really going to just talk about esophageal varices. Hemorrhoids are also managed surgically in a lot of cases. However, the rest of them are primarily managed medically. Splenomegaly we try to manage that as conservatively as possible. We try to avoid taking out the spleen because of complications from that procedure in patients with cirrhosis. Ascites we manage medically with salt and water restriction and diuretics. There are some surgical procedures that can be done, but they're secondary therapy. Hepatic encephalopathy is pretty much always managed medically, just because these patients are poor candidates for surgery in many cases. And then there's other issues, including hepatorenal syndrome, which is where the kidneys start to act up in the presence of liver failure, cutaneous manifestations, which I talk about in the portal hypertension lecture. Gynecomastia, remember that the liver is responsible for metabolizing estrogen, so if your liver is not working, you're going to have higher estrogen levels. And then hypogonadism. All right, so we're going to primarily talk about esophageal varices here. So now remember that I've been saying about surgical candidacy, and patients who have things like hepatic encephalopathy are poor candidates for surgery. This is something that's going to be really important to keep in mind anytime you're referring a patient over for a surgical procedure, because not all patients who have liver failure are going to be really good surgical candidates. As a matter of fact, patients with severe encephalopathy are pretty much always excluded from surgery. So the child's classification, you can put them into classes A, B, and C, and all you're doing is you're adding up the points. Now, you don't need to memorize this for the USMLE. You'll always be able to access this if you need to in a clinical setting, but it's good to know some of the various parameters that make a candidate a better surgical candidate or a worse surgical candidate, a poor surgical candidate. So some of the things that we look at first and foremost is encephalopathy. So encephalopathy is graded based on the frequency of asterixis that the patient has. Remember the liver flap of the hand. It's also graded based on their awareness, on their consciousness, and so that can be graded as none, mild to moderate, or severe. Ascites, then bilirubin, albumin, and prothrombin time. So these three things down here can be graded just simply based on the labs that you're going to get, your routine labs. Ascites, you'll want to, you can base your management on that based on whether or not it responds to diuretics, if it's even there. Some patients don't even have ascites. So these are the things that sort of play into whether or not the patient is a candidate for surgery. But you don't need to memorize this. Just wanted to kind of orient you to this. So the emergent procedures, we're primarily going to talk about just in relation to esophageal varices. So there are the EGD procedures that we can do, then there's also TIPS, and then some of the more emergent shunting procedures. All right, so patients with esophageal varices, they may not be symptomatic. So any patient who's diagnosed with cirrhosis, or let's say diagnosed who's chronically alcoholic, or who is starting to have liver failure, elevated liver enzymes, if you've diagnosed a patient with liver failure, you should be doing an upper endoscopy on them proactively to look for esophageal varices. And the reason we want to do that is because if there are esophageal varices in the patient with cirrhosis or with any kind of liver disease, what we want to do is place them on a non-selective beta blocker. So something like nadolol. And what that will do is it will reduce the likelihood of them developing variceal bleeding. However, what the beta blockers don't do is to help prevent future episodes if they've already had one. So if a patient has never had variceal bleeding before, but they have varices, then a beta blocker will help prevent them from having their first episode. It doesn't always prevent them, it just helps prevent them. But if they've already had variceal bleeding, it's not going to prevent any future episodes. So once you had one, the beta blocker doesn't really help anymore. So here on EGD is a non-ruptured esophageal varus. And here is a ruptured esophageal varus. Okay, now patients who have ruptured esophageal varices, we already talked about sort of what those are. They usually present as massive hematemesis in a patient with a history of long-standing liver problems, and that should be shown to you on a question on the USMLE. The patient has had chronic alcoholism or has had chronic hepatitis C for the last 20 years, and so this is not a surprise when it happens. The history is usually very consistent. And so this usually presents as massive hematemesis. However, it can also present as melena in a patient who has a slow esophageal varice rupture. There is a significant mortality rate, I think I read about 20 to 50%. So the history, usually alcohol abuse, IV drug use, which can put them at risk for hepatitis, cirrhosis, other liver diseases. The symptoms include melena plus or minus hematemesis. Usually it's massive hematemesis, though. You should be looking for signs of liver failure when you're looking at the patient. So things like scleral icterus, jaundice, ascites, spider angiomata, which is one of the cutaneous manifestations of liver failure, hepatosplenomegaly, gynecomastia. Patients may have symptoms of chronic anemia, and if they have severe blood loss, they may be in shock. A lot of patients with esophageal varices will present in shock because they vomited up a lot of blood. So this is a significant emergency. The labs you'll probably be given on step 2. Step 3, you're responsible for knowing to get these labs. The labs that are going to be important to get are everything that shows where your blood is at, what your liver is doing, and whether you've got any kind of coagulation issues. So first off, you need to get a CBC. CBC will usually show an iron deficiency anemia because usually there's been some blood loss for some time, or you've had the acute blood loss, or you may have anemia of chronic disease because you've got cirrhosis. CMP, this is going to be important because you want to know if the patient has got disease due to alcoholism or not. Anytime you have liver failure, you're going to have elevated AST and ALT. Oftentimes, it's going to be with a high AST to ALT ratio. Usually, that's AST to ALT greater than 2 to 1. If the AST to ALT ratio is greater than 2 to 1, then the likelihood is that this patient has liver problems due to alcoholism. You may also see an elevated ammonium on your CMP, and then the PT is usually elevated because remember that those PT factors come from the liver. Factors 2, 5, 7, and 9, I believe. Okay, now the best initial diagnostic step, in addition to the labs, the best initial step to make your diagnosis is an EGD. This is going to help you solidify your diagnosis that yes, indeed, this is a ruptured esophageal varice. So EGD is necessary to get in the workup for esophageal varices. The treatment is going to be administration of octreotide. However, the definitive therapy for most patients is going to be banding. If you can't get the banding done, if that does not work, then you can do sclerotherapy. However, banding is superior to sclerotherapy. Some of these other procedures that we're going to talk about, which are balloon tamponade, the TIPS procedure, and Portocaval shunting, these are second-line therapy. So they may be a wrong answer choice, but the best initial therapy is banding. So when a patient presents with variceal bleeding, what do? First, you manage their ABCs. So you need to secure an airway if necessary. If they've got consistent vomiting and if their oxygenation is less than 88%, 85%, then you're going to definitely need to secure an airway. Also, insert bilateral IV lines, large bore, and administer a normal saline bolus. We know that these patients are dehydrated because 1, they're vomiting, and 2, they're vomiting blood. So you're definitely going to be administering a normal saline bolus, at least 1. You're going to want to get stat labs, those labs that we just talked about, CBC, CMP, a type and cross match, because usually we're going to need to transfuse these patients, and then a PT and PTT, just your coagulation labs. We're also going to want to place an NG tube for suction and lavage. This is for 2 reasons. 1, we want to see if there's blood in the stomach. That's going to help us right away know that this is an upper GI source. If the hematemesis isn't obvious enough, it can also help us figure out if maybe perhaps if there's coffee ground emesis, maybe this is rather than due to a varice, it's due to an ulcer. So an NG tube for suction and lavage is important. Also, because when you're doing the lavage, it'll make it easier on the endoscopist because you're sort of flushing the stomach and the esophagus out. Then, of course, most importantly, the prompt upper endoscopy for banding. If that doesn't work, you can do sclerotherapy. The meds you're going to want to have the patient on: IV octreotide. That's going to help with the bleeding. And then IV broad-spectrum antibiotics. Remember, there are bacteria in the esophagus, and if there is a bleed, you can get bacteria into the blood, and that can lead to sepsis. So you want to administer IV broad-spectrum antibiotics, primarily focusing on gram-negatives and anaerobes. If banding and sclerotherapy fail, then you're going to place balloon tamponade. As far as IV broad-spectrum antibiotics, I would choose a 2nd or 3rd generation cephalosporin and metronidazole. Okay, so if you do your endoscopy and you try to band the varice but it doesn't work, and you try to do sclerotherapy and it doesn't work, then and only then should you place a balloon tamponade. And I suppose the other time you can place a balloon tamponade is if you don't have access to endoscopy. So by no means is this an initial therapy for the treatment of variceal bleeding. It's done only if banding and sclerotherapy are either unavailable or they fail. This is mostly done to buy time, hopefully allowing varices to maybe have some time to bleed, and preparing the patient, transferring the patient for a more definitive therapy, usually TIPS, possibly shunting. They should only be left in, the balloon should only be left in for 24 to 48 hours at the most, and the complications can be grave. So you can get esophageal rupture or perforation. Aspiration pneumonia is the most common complication, and that's just because there's nowhere for the oral secretions to go. And 20 to 50% of patients, the bleeding will resume on removal. So you're definitely going to want to have these patients sent somewhere where TIPS or shunting are available. Contraindications to placing a balloon tamponade at all include that if the variceal bleeding is slowing, then we will prefer not to put that in because maybe what we did worked. If they have a known esophageal stricture, we're not going to want to place this. And then most importantly, if they've had recent surgery at the gastroesophageal junction. So what are we thinking about there? We're thinking about maybe reflux procedures. All right, so the TIPS procedure, this is just short for transjugular intrahepatic portosystemic shunt, and this is a radiologically guided surgery. This is sort of your third line if your endoscopic treatments don't work, and I suppose if your balloon tamponade doesn't work, you're going to want to do TIPS. And what you do here is you're inserting, and generally this is done by an interventional radiologist, but they insert a catheter at the internal jugular vein, and they pass it along through the right heart into the inferior vena cava, past the diaphragm, and after the diaphragm, the hepatic vein is one of the first veins that are going into the IVC. So you pass it into the hepatic vein. Once you know that you're in your hepatic vein, then you're going to move this needle, and this needle is carrying the shunt, and you move the needle down into the portal vein. So now you've got a needle that's connecting your hepatic vein and your portal vein. At that point, then you inflate your shunt, and then you remove the catheter. So now you'll have a shunt between your hepatic vein and your portal vein, and this will allow for portal decompression through this shunt. This is the preferred surgical therapy, preferred to some of the open surgical therapies, especially in an emergent setting. The complications are stenosis of the shunt. That's pretty much any time you have a shunt, stenosis is possible. Thrombosis, failure of the procedure, and then anytime you're bypassing the liver, postoperative encephalopathy, because this blood is not getting detoxified by the liver. The contraindications include severe encephalopathy, polycystic liver disease, and severe right heart failure. Remember what you're doing. If the patient has got severe right heart failure, suddenly you're expanding the amount of blood that's going to be put into the right heart, and so you can get fulminant degeneration patient status, because now the right heart is getting more blood than it's used to. All right, so this is kind of a picture of what this looks like. So you're passing your catheter down, progressing your needle from the hepatic vein to the portal vein, inflating the balloon, and then leaving the shunt. As easy as that. That's all you need to know about it. Now, the emergent portocaval shunt is what used to be done before TIPS came onto the scene. This is vascular shunting between the portal system and the inferior vena cava. This requires open surgery, and because patients with cirrhosis have higher rates of mortality post-operatively, we prefer to do TIPS because it's less invasive. The absolute contraindications for this, and you need to know this, any patient with acute alcoholic hepatitis should never be operated on. Okay, they have about a 50% mortality rate when they're operated on. So they should never be getting these open surgeries. Acute alcoholic hepatitis, if you know they have that, even if you're concerned they have that, you will not operate on them. Other things include, as you probably imagine, severe encephalopathy and severe coagulopathy. So what do we see with a patient with acute alcoholic hepatitis? Well, of course, they'll have a history of recent alcohol intake. diffuse right upper quadrant pain, an AST to ALT ratio greater than 2.0. If you're sure that the patient does not have acute alcoholic hepatitis, fine. If you don't know, even with the history, the symptomology, and your lab work, then get a biopsy if you can't rule it out otherwise, because you do not want to operate on a patient with acute alcoholic hepatitis. Contraindication is severe liver failure. The reason I put that as contraindication as opposed to an absolute contraindication is because, well, pretty much any patient you do an emergent portocaval shunt on is going to have pretty significant liver failure. So it is under the contraindications technically, but you're kind of going to weigh benefits to risks. Remember, again, bypassing the liver increases the likelihood of hepatic encephalopathy. So liver procedures we're going to talk about are end-to-side portocaval shunt, side-to-side portocaval shunt, and the mesocaval shunt. Okay, I don't think you're going to be asked to decide which of these three to do, but there are a couple things that you should know. Okay, so this is the anatomic, just an anatomic diagram of the portal system with the inferior vena cava kind of running behind it. They're not connected anatomically. So you have your splenic vein, which picks up your inferior mesenteric vein, superior mesenteric vein becomes the portal vein, and then that goes on to the liver. And then you've got your inferior vena cava. So the end-to-side portocaval shunt is the most commonly performed. And what you're doing here is you are ligating the portal vein, and the portal vein will now be blind. So you'll ligate off the portal vein, and then the inferior end, you're going to attach it to the inferior vena cava. So now you've got decompression because your superior and inferior mesenteric venous systems, your splenic veins, are all moving into the inferior vena cava. This is good because it's easy for most surgeons to do. They do it often, and there's a very low rebleeding rate if the patient has had varices. The bad thing about it, as you can imagine, is that we're cutting off portal flow to the liver, and so all of this blood that's coming back from the intestines is not going to be detoxified. It's going to go into the inferior vena cava and then back into the systemic circulation. So you can get that hepatic encephalopathy, post-surgical hepatic encephalopathy. Okay, now the side-to-side portocaval shunt, what we're doing here is that we're creating, just like it says, a side-to-side anastomosis between your portal vein and your inferior vena cava. So I tried to illustrate it as best I could, but what you're doing is you're creating an opening in your portal vein and an opening in your inferior vena cava, and you're suturing the two together so that now it's almost as if the inferior vena cava was a tributary off of the portal vein. So this is good because it leaves the portal vein intact, and so you're not going to get that postoperative hepatic encephalopathy. It also decompresses the liver because when you have a high portal pressure in your liver, blood can now move retrograde back down the portal vein, and so now the portal vein can function as an outflow vessel. And this is really good in patients with Budd-Chiari syndrome. Remember, Budd-Chiari syndrome, you have thrombosis of your hepatic veins, the veins coming out of the liver. And in that case, the big problem is that you have elevated pressure in your portal vein, portal hypertension, because not because of anything wrong with the liver, but because you have blockage in your hepatic vein, so it can't get back. It can't get back to the systemic circulation that way. If you create this side-to-side portocaval shunt, the blood can go to the liver, and then it can go backwards, back into the inferior vena cava through this anastomosis. And so now you've got your portal vein functioning also as an outflow vessel. And remember that most of the blood going into your liver actually is coming from the hepatic artery, not from the portal vein. So now basically what you've done with this is you've changed the portal vein from being strictly an inflow vessel to being an inflow vessel and an outflow vessel. And it will primarily then be an outflow vessel. So this is good for patients with Budd-Chiari syndrome, the side-to-side portocaval shunt. It is a little bit more difficult, though, for surgeons to do. It's technically more difficult. All right, then finally the mesocaval shunt. This is done with a prosthetic graft, and just like its name would imply, mesentery, caval, vena cava. You're connecting the usually superior mesenteric vein to the inferior vena cava, and this is shunting blood out of the portal system into the inferior vena cava. Basically, you're doing the same thing as you were doing with your end-to-side portocaval shunt, except you're using prosthesis and you're not ligating off your portal vein. So this is done in other cases. You don't need to know when to choose one or the other. What you should know, though, is that the end-to-side is the one that's done most often, and the side-to-side portocaval shunt is really good for patients with Budd-Chiari syndrome. And with that, if you have any questions, feel free to let me know.